Good afternoon, and welcome to today's Electronic Visit Verification public webinar. Again, apologies for the need to reschedule this due to the technical difficulties last week. We appreciate everyone logging in today and checking things out. So just some housekeeping. All phone lines are muted for today's webinar. We ask that you submit your questions through the chat feature, and we'll address questions and comments at the end of the presentation. Please, please, please do not put your phone on hold, as that was an issue in our last presentation. So today's presentation is to provide some background to those of you who are new to EVV, as well as a refresher for others. We're going to discuss Pennsylvania's implementation of EVV, where we are currently, and address some of the common questions that we've received to date, as well as take your questions at the end of the presentation. The presentation today will be shared afterwards. So if you're wondering if you'll be able to access this information, we will be sharing this out through email to everyone who registered for today's presentation. We will also be posting this to the DHS EVV website. So just a little bit of background about EVV. Section 12,006 of the 21st Century Cures Act, which is federal law, established that all states are required to implement the use of EVV for Medicaid-funded personal care and home health care services. And states that do not comply with the 21st Century Cures Act will have their federal medical assistance percentage, or FMAP, reduced, and that's a loss of up to 1% of federal funding that will be graduated over several years. Under the 21st Century Cures Act, EVV must be implemented for personal care services by January 1st, 2020. The date was originally January 1st, 2019, but it was extended to January 1st, 2020. And then EVV must also be implemented for home health care services by January 1st, 2023. So EVV systems electronically verify the delivery dates and times of home and community-based services to the individuals needing those services. And EVV systems all aim to facilitate electronic documentation needed to record those services and, when necessary, capture a participant's verification. And that's all done electronically. And Medicaid home and community-based services are becoming increasingly more important as the need for them continues to grow. And this is mainly because we've shifted from institutional care to additional home and community-based services. That's based on some state and federal policies, as well as beneficiary preference to live within the community and receive those services. So the benefits of EVV include helping to improve the quality of care for individuals. It improves the accountability of those services and reduces the likelihood of errors or fraud. So also under the 21st Century Cures Act, there are 6 items that are required to be captured by an EVV system and verified. So those 6 items are the type of service provided, the individual receiving the service, the individual providing the service, the date of the service, the location of the service delivery, and the time the service begins and ends. And those are the 6 required items that must be captured by an EVV system. The other EVV requirements under the 21st Century Cures Act is that the system needs to be minimally burdensome, that it takes into account existing best practices, that it meets the requirements of HIPAA privacy and security laws, and that it takes into account stakeholder input and feedback. So the federal law also gave states the ability to decide the model that they want to use for their EVV system. Pennsylvania chose to use the open vendor model, and this was based on stakeholder feedback, in which we heard from providers that they were already using an EVV system and that we should really try to accommodate those existing systems. So under the open vendor model, the state Medicaid program contracts with a single EVV software platform vendor to provide an EVV solution, and then in addition to that, a data aggregator. And in this case, the providers may use their other EVV vendors or systems, which we phrase as alternate EVV. So again, under the open vendor model, DHS is working with vendors. Our vendors are DXC and SanData to develop an EVV system that will integrate with Promise, our existing Medicaid management information system. Those providers using alternate EVV systems will need to capture the 6 required items under the 21st Century Cures Act, and will also need to meet the DHS system data requirements in order to integrate with the DHS aggregator. We'll talk a little bit more about the system itself and the DHS aggregator in just a few slides. But first, let's go over what are personal care services. So currently we're focusing on the first phase of EVV rollout, which, because of the requirement that we implement EVV for personal care services by January 1st, 2020, that's why we are focusing specifically on personal care services at this time. And personal care services are those that consist of services supporting activities of daily living, such as movement, bathing, dressing, toileting, transferring, and personal hygiene, and also offering support for instrumental activities of daily living, such as meal preparation, money management, shopping, and telephone use. So under the Office of Long-Term Living Waivers, or OLTL, personal care services fall under personal assistance services, respite in unlicensed settings only, and participant-directed community supports. And those are agency and participant-directed services. In the Office of Developmental Programs, as you'll see here, the personal care services fall under consolidated person-family directed support waiver and community living waivers, as well as intellectual disabilities and autism-based services, which includes agency and participant-directed services that fall under companion, in-home and community support, respite in unlicensed settings and camp, as well as homemaker and chore, with the chore portion not included. Also under the Office of Developmental Programs, personal care services fall under the adult autism waiver, specifically community support and respite in unlicensed settings only. So again, for the first phase of DHS EVV implementation, which is for personal care services, DHS is working with DXC and SanData to comply with federal requirements for EVV by January 1st, 2020. The DHS EVV system will be available for personal care service providers who do not have their own system, but we also will be offering the DHS aggregator, which will receive information from alternate EVV systems being used by personal care service providers that have their own system. So again, the DHS EVV system consists of 2 pieces. It's the DHS SanData piece, which collects information directly into our system, as well as the DHS aggregator, which collects information from other EVV systems and aggregates that together for our purposes. So DHS EVV system being developed with DXC and SanData will be using 2 options to capture and verify visit information. And this is the piece that we are collecting information directly. So those 2 options are the mobile application, which is SanData Mobile Connect, as well as telephony visit verification. We also, as part of this, is the web portal, and corrections to visit information will be made through that web portal by the provider agency. The mobile application, we're using a bring your own device model for that, where caregivers may use their own personal devices, such as smartphones and tablets, to enter information and capture it. The application is available free of charge to be downloaded onto a smartphone or smart device, and it's available for both the iOS and Android systems. Within the mobile application, otherwise known as SanData Mobile Connect, the visit information is entered and captured through that mobile application, and the GPS location is captured at check-in and check-out only. I do want to stress that the GPS must be enabled for the mobile app to work, and the location is captured as GPS coordinates within the mobile application. In areas with no service, the information is stored until a device is in range and then uploaded. This is just an image of what the application would look like on a smartphone, just to give you a preview of what that would look like. So then the second option is telephony visit verification. In this option, the caregiver calls at the beginning and end of each individual visit, and the caregiver may use the participant's home telephone or a cell phone for the EVV process. Toll-free numbers will be provided and will be made available 24 hours, 7 days a week. The web portal allows for the provider agency to monitor and track information as well as make corrections. And the web portal provides near real-time capture of data. It has near real-time monitoring of information, provides standard reporting, and as said previously, it can resolve visit issues or errors immediately. And it also is the data to support claim submission. So just to walk through what the typical visit capture will look like, the caregiver arrives at the point of service, which is either the home or the community. The caregiver uses the mobile application or telephony to check in. That data is submitted. The caregiver then provides the service. Once the service is completed, the caregiver uses the mobile application or telephony to check out. Once that process is complete, the data is submitted. And then if there are any corrections that need to be made, the provider agency can make those through the web portal. I want to mention that in these instances too, the caregiver can check in with a mobile application and then check out with telephony or vice versa. So the DHS aggregator, which we discussed earlier, will allow providers to use alternate EVV systems. The data is transmitted from the alternate EVV system to the DHS aggregator. And the technical specifications were made available on the DHS EVV website a few weeks ago. We'll also be resending them out to the listservs in the next week or so. The providers choosing to use alternate EVV systems will need to work with SanData on their certification, and we recommend that you touch base with SanData now because this can take approximately up to 60 days for the certification process to really happen. So the contact information for inquiries specific to alternate EVV is there on the slide. The phone is 855-705-2407. Or you can also email them at paltevv@sandata.com. And again, this presentation will be shared with everyone afterwards. It is also on the website.
It's also included in the meeting invite that you received for this meeting and available right now.
So again, the DHS aggregator will compile all the information from alternate EVV providers as well as DHS EVV users, all into one funnel that we can then use here at DHS, all of that data to really look at and see how EVV is being used and how successfully it's being used. For OLTL providers, we wanted to make sure that if you are in Community Health Choices, there are 3 CHC managed care organizations that are using their internal systems to meet the EVV requirement. And all 3 MCOs are utilizing HHA Exchange for EVV. Just so you're aware, HHA Exchange then will be sending EVV data to the DHS aggregator.
And that kind of addresses a question we received as well. When we're talking about the DHS system through SANdata that we're offering free of charge to providers, that is for the fee-for-service environment. That SANdata system and the aggregator will be directly interacting with Promise. Since the MCOs in CHC do not directly interact with Promise, and the providers in Community Health Choices directly bill the managed care organization, the HHA Exchange system will be the system the MCOs are offering to their contractor providers free of cost, and that system will be the system providers will need to work with in Community Health Choices. If they have their own EVV system, they'll need to send that EVV data to HHA, and HHA will act as sort of an intermediary aggregator within the Community Health Choices program.
So also, additional OLTL providers under participant-directed services, OLTL's vendor fiscal agent, Public Partnerships LLC, or PPL, will also be using their own internal system to meet the EVV requirement. And this system is already integrated with PPL's timesheet and payment system, as well as their participant and direct care worker online portals. So an update on where we are with our system implementation. Our business rules are finalized. We posted some frequently asked questions to the DHS EVV website, and we will continue to update those as we have additional questions that are coming in. We also have finalized and posted the alternate EVV technical specifications and DHS addendum. Those were posted on the DHS EVV website, distributed through our listservs, and were also emailed directly to requesters. Additionally, our system testing is currently underway, and provider training will begin in September 2019, and that includes aggregator training, the DHS SANdata system training, as well as fiscal agent and participant-directed services training. All that training is mandatory, which we'll discuss again. So looking at the timeline, this month we plan to send out another email regarding the alternate EVV requirements. Again, reminding anyone that if you are using an alternate EVV system, that you will need to work with SANdata to get that system certified so that they can share the information through the DHS aggregator. We'll also be sending out a provider readiness checklist for those providers that are planning to use the DHS EVV system directly to capture that visit information. And we plan to send that out within the next week or so. Next month, the training registration announcement will be sent out. And when I say that these will be sent out, they will be sent out through the listservs. So either the OLTL or ODP listservs, as well as the EVV listserv. So if you would like to join the EVV listserv, if you email us at the EVV resource account that's listed on the last slide, we will be happy to add you to the EVV listserv in case you're not on any of the other listservs. So also in August, at the very end of August, we are hoping to finalize the system. And then September, we're looking at a program launch announcement, as well as the mandatory provider training that will begin in mid-September. Which leads us to October 2019, which we consider our soft launch date. That's when we expect users to either have the DHS EVV system that they're using, or if you're using an alternate EVV system, that you have the ability to integrate with the DHS aggregator and send us that information. And again, that is all leading up to the January 1st, 2020 date, when we need to have the full implementation of the system as required by the 21st Century Cures Act. So a little bit on provider training. The training will be made available to provider agencies only. It's a mandatory provider training that will be offered with phased-in system use. We expect 2 provider agency representatives to attend the mandatory provider trainings. And the training will be provided in classroom settings as well as through live webinar. We'll also offer self-paced, but the classroom and live webinar training attendees are then responsible for training additional staff on both the mobile application and telephony, and then other office staff on the administrative functions of EVV or the web portal portion. So as I mentioned, we'll have 3 actual options for the training. It's classroom training, webinar training, and self-paced training. The classroom and webinar trainings will be offered September 16th through October 25th. And the registration information, as mentioned previously, will go out next month. So be on the lookout for an email next month about registering for training. Additionally, we'll have the self-paced training, which SanData offers the learning management system, and we'll be sure to share the link for that system to anyone who would want to use the self-paced training system. And again, classroom and live webinar training will be offered September 16th through October 25th, 2019. And self-paced training will be available both before and after the soft launch date. So the locations, dates, times, and registration instructions for the various trainings will also be posted on the DHS EVV website once we have them available. And we included the link here to take you directly to the DHS EVV website.
EVV should not change your delivery of your services. Participant information remains private and protected, and caregiver clock-in, clock-out for PCS will be done electronically. Participants may need to verify services via mobile phone or telephone. Caregivers may ask to use a participant's phone. However, this is not a requirement, and it is the participant's choice to allow the caregiver to use the participant's phone for EVV. Again, EVV should not change the delivery of services. Caregiver information remains private and protected, and caregivers are responsible for electronically entering visit data. DHS does not require the use of one type of EVV over another. The DHS SanData Mobile Connect allows caregivers to use their own smart device, but telephony is another option for caregivers. DHS will not cover the costs associated with smart devices or phones. Caregivers should receive training from their providers. Providers should share EVV information with employees and participants. Providers should determine their EVV system, but DHS does not favor one type of EVV system over another. We just want to make that very clear. If you are using an alternate EVV, providers will need to ensure alternate EVV system captures 6 data required points and can interface with the DHS aggregator. As Britt spoke about earlier, this will take about 2 months to get done, depending on your vendor. That is why we're requiring that certification process. Be sure to review alternate EVV technical specifications and DHS addendums on our website. They will be updated frequently for all to see on the EVV website. Contact SANData with alternate EVV questions with the phone numbers listed on the website. If you are using the DHS EVV system, providers will need to complete the training and receive login credentials beginning in September of 2019. Providers will need to train their staff and provide assistance to employees having difficulty using EVV. Providers will need to review the remittance advice to monitor claims to identify issues that need to be addressed beginning in October of 2019. The full list of services can be found in the alternate EVV ODP and OLTL addendum listed on the website. We've had some questions come in about tasks, so we wanted to make this note. The tasks may be captured in Visit Notes section of the mobile app of the DHS SANData aggregator system. DHS does not require, however, providers may require under their business practices. As far as costs, DHS is not charging for the DHS EVV system. Providers using an alternate system may be charged for that system. Providers are responsible for any interface costs to integrate with the DHS aggregator. As far as connectivity, in areas with no service, the information is stored until the device is then in range and then will be uploaded. DHS does not prefer the use of the mobile application over telephony. Caregiver may use the mobile application for check-in and telephony at checkout, or vice versa. Devices. Smartphones are not required for the DHS EVV system. DHS is not providing devices nor paying for any data plans associated with phones or smart devices. In reference to location, providers will be able to enter multiple addresses where services are provided, and addresses can be updated as needed. A quarter-mile perimeter set in the DHS EVV system, but even if recorded location is outside the 1/4 mile perimeter, this will not cause an exception in the DHS EVV system. Exceptions. For the initial phase, exceptions are generated by the DHS EVV system when one of the 6 required items is missing. As far as good faith effort exemption, we are not planning to submit a request to CMS at this time. We will continue to review and evaluate options as implementation continues, but as of this time, we are on track. Please stand by for a moment while we collate the questions that have come in so far. I will make a note, we will compile all the questions, and there are an extensive amount of questions that have already come in. If we do not answer your specific question today during this call, we will be compiling these questions into a document and posting it on the EVV website with an answer. Not all of your questions can be answered today, but we will begin to answer some questions in a few moments. Please stand by. Please note that on this slide, we are listing all of our upcoming meetings that are EVV public meetings. They will be held in this same forum. Questions can be submitted in advance to the EVV resource account, or we will answer them during the call as best we can. So please note that the December 31st meeting is subject to change based on the date and the holiday. There are some questions that have come in that we've answered and or have already been answered in the FAQ, or frequently asked questions document, that is already posted to our website. So we encourage those of you who are on the line who perhaps have not seen that to investigate that document. So we will not be answering some questions that have already been asked and answered. But the first question we'll address today is, if you have one staff member who is relieving another staff member, does EVV allow for agencies to determine rounding rules? With the unit, if you have one person who works for 14 minutes, that would not be billable for a full 15-minute unit, correct?
So it's important to note that both the Office of Developmental Programs and the Office of Long-Term Living have different policies for rounding rules. Those existed before EVV, and those rules will remain the same. So we have built the EVV system to accommodate the different program rules for rounding. So for ODP programs and OLTL programs, you will follow the same rounding rules for each of those programs as you have followed in the past. And in the future, we do intend to provide some sort of document outlining exactly how those rounded units will appear, how many minutes will round into a unit. But it's really just going to be a tool, a reference for EVV. It will not be any new type of policy. It will be the same rounding rules. We did have a question about residential habilitation services and whether or not they fall under the EVV requirement. For OLTL, residential habilitation is not included under the EVV requirement. We will have to follow up in regards to whether or not residential habilitations under ODP are included, but I do not think that they are, and they were not listed in the beginning of the presentation.
The next question we have is, whether you use the DHS EVV system or go through the aggregator, will the data automatically submit billing to Promise for the services rendered?
So the SANDATA EVV system does have an optional module for billing. If you choose to use the SANDATA system, you can also choose to use their billing module. And what that will do is it will take your EVV data and automatically help you process that submission to Promise. If you are using an alternative system of some sort, whether it's a proprietary system or an alternative vendor, whether or not that type of interface will happen with Promise really depends on what your vendor offers and if there is any type of billing module that you have with your personal system. So the only system we can say for certain that will assist you with billing is the SANDATA DHS system if you were to elect to use the billing module. So there was another question here, whether or not there are one or more types of telephony companies that are accepted. If you're using any type of telephony company and you need to either send that data to the DHS aggregator or the CHC system, you will need to work with SANDATA or the contract vendor HHA Exchange with the MCOs to make sure that whatever system you're currently using is collecting all of the information necessary to be compliant. The best thing you can do is at least start looking at the data points that we've outlined in the technical specification document and provide that to your telephony company. That technical specification document is going to give you a pretty clear idea of whether or not your system will be able to interface with the other vendors.
So the next question is DXC SANDATA just for ODP billing, or can it be used to bill MCOs in CHC?
So just as a reminder of something that we touched on earlier, the SANDATA system will be directly interfacing with Promise for billing, but it will not be directly interfacing with the MCOs to send them information. The MCOs have elected to use their own system because they had that choice under the open vendor model, and because they're using HHA Exchange, you will either need to use HHA Exchange or an alternative system of your choice to send billing information and EVV data to the MCOs. Someone did ask a question about whether or not ClearCare will work with the systems that we're implementing. As previously mentioned, you can look on our EVV website and reference the technical specification document for alternative vendors, and you can have ClearCare and SANdata work together to make sure that they are able to be compatible. A question regarding whether or not an agency could use a combination of systems. So could they use their own system they have already implemented for their company and also using SANdata's system through DHS either as a complement or a backup? That, as far as I understand, that is absolutely up to you. That's a business process for you to develop, and if you want to have a complementary system of some sort, as long as you have business practices in place to make sure that you are satisfying the requirements and all of the data is going to the correct location, that's absolutely your decision as a business. So there was a question about whether or not this webinar applies to providers providing services for the Community Health Choices waiver. For the OLTL programs, EVV requirements apply to the OBRA, Act 150, and CHC waivers. The reason that we are not currently requesting that aging, attendant care, and independence waiver providers implement EVV within the fee-for-service environment is because as of January 1st, you will be in CHC. So we would rather you direct your efforts as an aging or attendant care or independence provider, direct your efforts toward working with the MCOs to make sure you're ready to use EVV on January 1st in CHC. Bear with us, we're going to consolidate a couple more questions.
Just a reminder that the PowerPoint has already been shared. It is up here, but it will, after the meeting, it will be on the EVV website.
So there's a question regarding kind of what a provider needs to do if a worker missed, say, a clock in or a clock out. You know, they forgot or they couldn't get the device to work whenever they clocked in, what have you. We absolutely understand that this is going to happen, especially as we implement, and this is new to people, that they might forget to either clock in or clock out of the visit. So agencies will have the ability to work with their worker to make sure that that time is corrected. All agencies will be able to go into the system through their office, access through a desktop computer or a laptop or something like that, and correct those visits or add missing information. So we've had quite a few different questions about self-directed programs. So I want to take a little bit of time to try and answer quite a few of those questions. Self-direction will maintain the same kind of common law employer independence through this process. So common law employers will have direct interaction with the EVV system. They will continue to approve or deny time in EVV, just as they did with the timesheets. And depending on which program they're in, there's going to be a slightly different approach. I know that in the Office of Developmental Programs, they're still working with PALCO to finalize PALCO's approach to how they're going to handle EVV and what vendor they're going to select. But in OLTL programs, public partnerships is the FMS vendor for all participant-directed programs, and they have selected to use their own internal EVV system. So they have already started their first couple communications to common law employers and direct care workers, and throughout the summer they will start training both common law employers and direct care workers on the system. And they will also be providing customer support to both the direct care worker and the common law employer to get them up and running with the system. But the important thing to remember is the common law employer will still maintain the roles that they had before in approving or denying the timesheets and scheduling their worker. There have been quite a few questions as well that we have received regarding providers who are already in Community Health Choices and are already using HHA Exchange. If you are a provider already in CHC and you're using HHA Exchange and you do not have any other participants that are still in the OBRA waiver or in any other type of fee-for-service waiver, if the only entity at this point that you're working with is a Community Health Choices Managed Care Organization, that is the only entity you're going to need to work with EVV. So if you're already using EVV with the MCOs will continue to communicate any changes they might have with their system, but there is nothing else that you need to do to integrate with SANdata at this time. If you still have participants, though, in the final phase 3 region who will move to CHC January 1st, you'll just want to make sure that you're ready to go and you have those direct care workers and those participants ready for the fact that EVV will be used through HHA and the MCOs on January 1st. We have another question here that asks if a provider works with both ODP participants and OLTL participants in CHC, do they still have to integrate with SANdata for the ODP participants and HHA for OLTL? And yes, that is correct. If you have any participants in any of the fee-for-service waivers that fall under the EVV requirement, you will need to have your system integrate with SANdata so that it can go to the DHS aggregator and assist in validating claims that are submitted to Promise. And then if you are working with the CHC MCOs, you will need to work with them to either integrate your system with HHA Exchange or use HHA Exchange as the EVV solution. Bear with us. We're continuing to consolidate questions. We'll be back with you in just a second. So we did receive some questions about group and residential services, and we're going to have to take those back. There's quite a few different caveats depending on what's being referred to by group or residential services. So that's something that we would be able to spell out in more thorough detail in some type of question and answer document as follow-up to this. We also received a question about clustered living arrangements. So under OLTL programs, we do have the clustered living version of personal assistance services. Those have been, clustered shared living has been excluded from the EVV requirement based on CMS guidance that was provided around congregate settings and what was and was not mandated under the 21st Century Cures Act. So we will not be implementing EVV for clustered shared living arrangement services under OLTL programs. So I do see a question here regarding if a provider has multiple companies, whether or not they need to do mandatory training for each company. We would need more clarification on that question. If you don't mind being able to provide us a little more detail on exactly what you mean by that question, we'll be able to better assist you. So there was a question here of whether or not it is accurate if providers will need to have their own EVV system or if they can just use the DHS system. So as we mentioned before, the SANDATA EVV system is the system being provided by DHS free of cost if providers choose to use it for the fee-for-service programs under OLTL and ODP. And HHA is the system through the managed care environment under Community Health Choices that is being offered by the MCOs free of cost to the providers. So if you do not have your own EVV system, you are able to use either one or both of those to satisfy the requirements based on the programs that you're enrolled in. There's another question here. What happens if a caregiver is not willing to use EVV? And this is absolutely going to be an adjustment for caregivers. I know that not all companies have started using EVV, so this will be new to many people. But this is a requirement as part of how time is now collected and verified that services were provided. So it's really important that you develop kind of a training and onboarding process with your workers to really introduce to them and help them understand the benefits of EVV, the benefits of really not only how this is going to improve services for the participants, but also how this can make their process a lot easier throughout the day than some of our older paper processes that weren't necessarily always as timely with submission or accurate. So we'll be providing additional resources to you as far as guidance on, information that could be provided to your caregivers, but it's really important that you work with your caregivers and help them understand EVV so they're more willing to embrace it. We had another question regarding when a participant would need to verify the times for service. So those policies will continue as they have today. If your programs have required in the past that participants signed off on time, that will continue. The main area where that occurs is in participant-directed services, where the participant is the common law employer. Those participants are required to continue to verify the time that is submitted through EVV. If you bear with us, we're just going to continue to collect additional questions that are coming in. We received a question regarding whether or not EVV will replace the 837 billing process through Promise. It will not replace that. So you will still need to continue to submit your 837s unless you choose to use the billing module through the SANdata system that will automatically consolidate and create that submission for you. You'll still have to submit that through the data system, but there will be some automation there to group your EVV claims information and your 837 information together as one submission, but this does not replace the 837 submission. So we have a question here as to where an agency would be making corrections to their EVV visits. And in this specific scenario, they're asking, would they use their internal system, ClearCare, or would they make the corrections through HHA since they are integrating with the MCO system? If you have not submitted the visits to HHA at that time, if it's a visit that just came through ClearCare before it's submitted to the MCO, you can absolutely continue to make those visits through your system. In regards to whether you change the visit after it has been submitted to HHA, you'll have to work with the MCOs in determining that process just because every system is set up slightly differently. So you'll want to work with them on a corrections process once it has been submitted to them. And then there was another question here about whether or not there is a charge to interface with the system. And I'm not sure if which system we're referring to here, whether it is SANdata or the MCO system. But for SANdata, there is no charge from SANdata to integrate with the system. But we cannot guarantee that your EVV vendor might not have some sort of charges that they might require of you to do that integration. And just an additional question regarding which services are applicable to EVV. Community participation supports through the Office of Developmental Programs are not subject to EVV requirements. Once again, we're going to just continue to consolidate questions. We'll be back in just a second.
So there's a question here, are there any additional EVV providers already approved by SANDATA? If so, can we get a list of who? So we appreciate the question. EVV, or SANDATA has developed relationships with numerous outside EVV vendors. So there's actually only going to be a very small percentage that they have not already worked with. We do not have that list and will not post that simply because regardless of whether SANDATA has worked with that provider or that vendor in the past, you will still need to get certified on your system. It just, for those who they've already developed a relationship with, it'll go a lot quicker. So that should answer that question.
So we had a question here about kind of services in the community. So if a provider is picking up a participant at their home and transporting them to a community location, is check-in done at the pickup or at the arrival at the community location? So what's important here is that EVV does not change how services are provided. If in the past this was part of the service plan to provide services that included transporting someone into the community, you continue to provide those services in the same way that you always have. So how you provide services today will determine when you clock in and clock out on EVV. Just because you are going into the community does not mean that those services are not allowable under EVV. Services can be provided anywhere at any time. And just because you clock in at the home location doesn't mean that if your shift ends in the community and that participant is either starting another shift with another worker or they're going to a family member's house or what have you, you can clock out at a different location than you started the shift. There's no limit as far as the participant being able to continue to integrate and interact with their community activities. Someone else asked if EVV will replace the service note requirements. So the EVV SANDATA, the SANDATA DHS system does have the ability to collect service notes. It's just a free text field, but it is just for any provider to use for any reason they think there might be some useful information, but it does not automatically satisfy the service note requirements. EVV requirements that are being satisfied through this implementation are just that. They are satisfying the 21st Century Cures Act. As far as your ongoing other compliance requirements, including service notes and other billing, claims, auditing requirements, you'll need to continue to work with your program offices to make sure that you're compliant with all those different requirements, but EVV does not automatically cover other program requirements outside of just the EVV requirements. And we'll be back in just a few minutes. So the next question we have here is in regards to how service locations will be determined. So if a staff person meets up with an individual in a community setting to start their shift, how will that location be referenced as an approved service location? So this could look a little bit different depending on your EVV system. So I'm just going to speak to the SANDATA system for right now for simplicity's sake. The SANDATA DHS system captures the location when the provider clocks in and clocks out. And it uses GPS coordinates to identify whether or not that clock in or clock out is within a quarter mile of any of the registered locations that are tied to that participant. A provider can add as many registered locations as they would like to the EVV system. So if on a regular basis you know your worker clocks in and out from 3 or 4 different community settings throughout a week, you can add all of those to that participant provider profile so that they register with the participant as it clocks in and clocks out. If the worker is not within a quarter mile of any of the approved locations, it will not stop services from being provided. We acknowledge that there's a lot of complexity when it comes to community-based services and the variation in location throughout the day or the week or the year. So what we're trying to do right now is really just learn about how useful this location information is and how we can better use it in the future. So right now, we do want addresses to be added if they are locations where services are being provided, but we will in no way inhibit services from occurring outside of that location just because for some reason it was a one-off day where they went to a new location, or just because it had not yet been an added location by the provider at that point.
I would just add that the GPS is only through the mobile application of the DHS SANDATA system. If you're using telephony, that is just the address that is associated with the phone number that is used for the call-in.
So our next question is regarding whether or not staff schedules have to be uploaded prior to a visit. Once again, that's really going to depend on the EVV system that you use. If your EVV system requires a schedule to correlate with a clock in and clock out, you'll have to continue that process. For the SANDATA DHS system, there is the option of using a scheduling module. We understand that some providers may already have their own method for scheduling and they don't want to use something like that, so it is not required, but you will have the option to use the SANDATA scheduling module, and that will integrate with the provider clock in and clock out as it occurs. So there's a question here as, what if a direct care worker does not have their own personal cell phone and the person they're providing services to does not allow them to use their phone to clock in and out? So this could lead to quite a few different options, and providers will really need to think about and work with their workers to figure out what the best solution is. There are programs to assist people in getting cell phones. Providers could assist their worker in obtaining a cell phone through one of those assistance programs. Some providers have also elected to provide a tablet that stays in the home at all times. They have a designated device for the home, and they have multiple workers that may be working in that home throughout the week, and all of the workers use that tablet that has been assigned to that home throughout the week, and they only need one device then per participant. So really, we're all going to have to get creative in kind of thinking about how devices for EVV can meet each individual participant's needs as well as the worker's needs. There's just a lot of variables as far as the setting, location, the preferences of everyone involved. So it really will be a case-by-case basis. There's a question here in regards to whether or not agencies will have the ability to review what the worker submitted prior to a final submission for billing. And absolutely, the agency will always have the ability to review the submissions before billing. And at least for the SANDATA EVV system, and I know many EVV systems operate in a way where just because that EVV visit occurred, there still does have to be that final submission step through the back office of the agency so that it goes to Promise or the MCOs. So you will still be able to view and maintain all of that information. And if you'll bear with us, we'll be back with you in just a second. Thank you.
We had a question come in as to where they can find the FAQ document, and it is available on the DHS EVV website.
We have a question here regarding missed visits with HHA, and I think the question here is in regards to a requirement in community health choices where providers are requested by the MCOs to submit missed visit data through HHA. This does not replace that. You'll still need to work with the MCOs regarding those missed visit data requirements. Whether or not the MCOs have some type of plan to automatically track that through EVV is really going to be up to them. So I would work with each one of them directly to find out if or how the missed visit reports that you currently submit would be impacted. So we have a question here about services that are provided at a 2-to-1 ratio. So there are 2 workers providing services to 1 participant at the same time. And those 2-to-1 services are included in EVV, and they will require that both workers clock in to the EVV, clock in through the EVV system that is being used to validate that that service is being provided. So 2-to-1 services continue to be provided as they are today, but both workers will be using EVV. So we received a question regarding any type of non-electronic verification requirements. So this provider has been using EVV for quite a while now, but they still keep physical time logs when the system goes down or there's any type of system issues. It is important that every agency sets up some type of backup protocol with your workers for how you expect them to continue to clock in and clock out if the EVV system isn't working. We all experience technical issues, and we understand that some days things are not going to work, whether it is the phone that is broken or the system itself for some reason is not working. So it is up to the agency to develop a process to make sure their workers continue to know how to clock in and clock out. So if that is some sort of paper documentation or that is a phone call they should be making from the home to your agency, it is important that you establish a backup plan with your workers in scenarios where the EVV technology for some reason is not working. But you will always be able to go back in once that system is up and running again and go into the system through your back office and begin to add and correct those visits in the EVV system. So we had a question here. If providers are able to use EVV for other services that are not mandated under the CARES Act, and the example they provided was supported employment. As a provider, you are able to decide how EVV best fits with your agency operations. And many providers have been using EVV for years, not only for the services we're talking about today, but for other services as well. So it is absolutely up to you as far as how useful you find EVV and how you want to integrate it into your operations. But we're really just discussing at this time what is needed to satisfy the federal requirements. And we will continue to consolidate questions. Thank you all for all of your questions. We have a lot of them. And we'll be back with you in just a second.
Bad for you.
By the way, everything that we mentioned that is on the website is visible on the screen. Just thought I'd point out the website for you. It'll actually be going through a bit of an improvement very shortly here, but we just wanted to kind of point out what the website looks like and where you can get to documents such as the EVV implementation updates that we'll be posting for, periodically. You see that we have the EVV FAQ document here, and we'll be updating that significantly after today's call. We will answer all of the questions that we were not able to get to live.
So we had a question, are residential group homes under the consolidated waiver included as part of EVV? And they are not subject to EVV. We had a question regarding whether or not EVV was mandated for the options program, and options is not required to use EVV based on the federal requirements. We also have quite a few questions regarding what will be expected for compliance in regards to the number of visits submitted without some type of correction by the provider. We are still awaiting on guidance from CMS regarding this issue, but we will in the future provide additional information about compliance expectations for EVV visits, manual visit edits, things like that.
So we have a question here regarding if a provider is providing home care, do they wait until the implementation in 2023? And I think it's important to draw the distinction here. Home care could mean one of two things. Right now, we are implementing EVV for personal care services, and that includes personal assistance services and the other services that we outlined earlier. If you are providing home health services or nursing services, those specific services will not need to implement EVV at this time, but you should be paying attention to updates in regards to the 2023 implementation that will be coming in the next year or two.
A question came in asking how are providers letting us know whether they'll be using the EVV, the Pennsylvania DHS EVV system through SANDATA or some sort of alternate EVV system. So anybody who's coordinating with SANDATA for the alternate EVV will know that, of course. But if you'd like to just shoot us an email on the resource account letting us know you'll be using the Pennsylvania DHS system, we would greatly appreciate that. We'll be starting to keep that list.
So we've had a number of questions regarding the mandatory training, and just wanted to address the one question was whether or not each provider agency would need to send 2 individuals to each day of training. We're only expecting provider agencies to attend 1 day of the either classroom training or the live webinars, and so we're only looking for 2 individuals to attend that training, or whatever training session you decide on. And then also, we will be sharing additional information about the trainings that will be sent out through the email as well as posted online.
So we have a question in regards to a provider who is currently using HHA Exchange for EVV, and they're wondering if they can also use HHA Exchange for their ODP programs. So if you're already using a system, or you've already selected a system, or even are just interested in SANDATA versus HHA, or another system that you're looking at, you'll need to reach out to those vendors and talk to them about what they can do to meet the needs of your business. So in this particular instance, if you're using HHA Exchange with the MCOs and you like the system, it is outside of the scope of how you're using it within CHC to begin using it with ODP, but that doesn't mean that you can't reach out to HHA and ask them about how they might be able to expand the scope of their system to meet your needs for the ODP programs. It's the same exact thing with SANDATA. If you are interested in using the free system being provided by DHS for fee-for-service participants, but you also want to use it for other services that you provide outside of the scope of EVV, or you want to ask about using it in the CHC program, you'll have to reach out directly to SANDATA or any of these vendors and talk to them about what they are able to offer you outside of the scope of the free systems we are talking about. Just keep that in mind. When we're talking about the free systems provided by HHA and SANDATA through our programs, they are just that. They are the basic free systems we are offering, but that does not mean that you can't work with those vendors to enhance the systems to meet all of your needs. We've continued to receive some questions about the common law employer's role in approving time. And if the common law employer denies the time, or they do not approve of the time for whatever reason, they still maintain that right. And depending on how the EVV system works, that will need to be corrected. In the PPL system, if that timesheet is denied, the direct care worker will be notified that their employer denied their time, and they will need to go in and make that correction or speak with their employer and work with them to correct that timesheet. For the other self-directed programs, some of that final process will depend on the EVV system that they choose, but they will ultimately maintain the right to deny a shift. So we had a question regarding the GPS technology. The EVV systems, in order to capture the location, they will request when a worker clocks in or clocks out that you enable the location services on the phone. That is just at clock in and clock out. If the worker would like to, after they clock in, turn the location services back off on their phone, because it could impact other applications, they're absolutely more than willing or more than able to do so. The location just needs to be captured at the clock in and the clock out. So you do not need to leave location services on your phone throughout the day. We had another question regarding location. If there is no cell phone or internet access when the worker goes to clock in, how will the GPS location be captured? The application will work regardless of whether or not you have cell phone or internet connection. The GPS coordinates will also be collected at that time. Your phone, smartphones are not relying on internet to collect that GPS location. So that should still be collected, and it will be saved in the SANdata system, and it will just need to synchronize back with the main system when you regain internet or cell phone access, so that it will synchronize with the agency office and be able to be sent to the aggregator. So it's important to remember that although we consider EVV an almost real-time tool, if there is no internet connection at the time, the agency might not be able to see a visit that is just started if they have not yet regained an internet connection, and that entry cannot synchronize with the main system. We did have a question regarding the CommCare waiver and how CommCare waiver participants will fall under these requirements. So I just want to remind everyone that the CommCare waiver was discontinued at the start of Community Health Choices. So all CommCare waiver participants were transitioned into Community Health Choices or were transitioned into the Aging or Independence waiver through the end of this year until they transition into CHC on January 1st. As far as if additional information needs to be added into HHA Exchange, we have a provider asking if the process will change. So currently, providers servicing CHC waiver participants, it states that they are not able to add address locations to the demographic records. So if you need to add additional information for EVV through HHA, you'll have to work with the MCOs on developing a process for how that will have to occur. And we're going to continue to consolidate questions. We'll be back in just a few minutes. Thank you. So a new question we received is in regards to recipients receiving multiple services throughout the day. So if a provider is there throughout the day, but they are actually there providing multiple different services at different times during the day, would the worker have to clock in and clock out each time they switch that service? And because at that point you are billing for different services, even though it is the same worker, you would have to have separate EVV visits for separate services. And just a reminder, we're getting a lot of questions that are very specific scenarios. So if you do not hear your question answered today, we will follow up in some form, whether it is updating the FAQ document or otherwise providing follow-up answers to this presentation. So thank you. We did have a question here about the process with agency with choice providers through the Office of Developmental Programs. So providers and participants and managing employers working in an agency with choice model will need to work with each other and the Office of Developmental Programs to make sure that they're satisfying the requirements for that model. But we do understand that there are unique circumstances to that model of service, so additional guidance will be provided. So one question is in regards to whether or not multiple workers can use the same device for EVV. And yes, if a worker is using either a landline telephone or a smartphone, they will log in whenever they start and end the visit. So multiple workers can use those devices and they'll be able to log into their own personal accounts to begin and end that visit. I think we just have a few more questions here, so we'll be right back. And then the last question we have here is in regards to travel. So if a direct care worker and their participant are clocking in from a different city or even a different state because of any sort of travel, will that be an issue with EVV? And it will not. Any type of travel that occurs as part of service provision can continue as it always had in the past. Once again, we're not changing how services can be provided either in the community or even in out-of-state travel circumstances. So you'll still need to follow the same policies as always regarding what services should be provided as part of the service plan, but EVV will not limit that. And with that, I think we've gotten through all of the questions. So we'll just...
If there are any additional questions, please send them through the resource account. If you want to make sure that that's up on the slide for everyone to view. We appreciate all of your time and joining us today, especially since we had to reschedule. And again, we will be sure to post updated FAQs to the website, and we'll be sure and address some of these additional questions at the next presentation scheduled for August. Thank you very much.